let's see.
Okay, I think we're ready to get started. Welcome everyone to our Clinical Conversations program. Just as a reminder, this program is a webinar series that takes place on the fourth Tuesday of the month. And we're really excited about today's topic. And it's a topic we've discussed in the past in this program, but we really can't overemphasize the importance of this particular topic because it really speaks to kind of an avenue for really addressing a significant kind of clinical need that often just gets missed and is associated with really significant morbidity and mortality. And it's the topic of psychosis screening in primary care. Just as a matter of housekeeping, we are recording the session as usual, and it's going to be available on the MCPAP website, so please pass this along to your friends and colleagues at www.mcpap.org. We also will have a copy of the slides available on the MCPAP website under the News and Webinars section. Our presenters will stop for questions at several points during the presentation, and there will also be time at the end for questions. If you have a question or comment, please just type into the question box during the presentation, and we will read out your question, or if you prefer, you can ask us to unmute your line so that you can ask your question verbally. You will receive a very brief survey at the end, and we really would appreciate some feedback just so that you can help us to improve future presentations and give us ideas of things that you would like us to include in our program in future sessions. So with pleasure and honor, I'm really pleased to introduce our three panelists for today. The first is Kristen, what's that?
Next slide.
Oh, could you advance the next slide, Beth, with their names? Wonderful. So actually, I'm gonna I'll go in the order of the slide. So the first person is Dr. Emily Feinberg, and she is a PsyD and a clinical pediatric nurse practitioner, and is the associate professor of pediatrics at Boston University School of Medicine. She has a background in maternal and child health and has specific training and experience in the conduct of community-based experimental studies. Her research focuses on developing effective interventions to support family well-being among young children with developmental risk. And Dr. Feinberg works clinically at the Dorchester House Community Health Center actually for 20 years. The next panelist is Dr. Kristen Woodberry, who is a clinical social worker and a licensed clinical psychologist with over 25 years of experience working with families of young people with or at risk for schizophrenia and other major mental illnesses. She obtained her MSW from Simmons College School of Social Work, and she has her PhD in clinical psychology from Harvard. Dr. Woodberry was an integral part of the development of clinical and research programs at the Beth Israel Deaconess Medical Center, working to identify and treat clinical syndromes associated with high risk for imminent psychosis. And in 2018, she moved to Maine to become a faculty scientist in the Center for Psychiatric Research at Maine Medical Center Research Institute, and is a research assistant professor at the Tufts School of Medicine. She continues to maintain strong relationships with Massachusetts partners, particularly on a pilot psychosis screening study to support an application for a larger scale NIH trial. And then last but not least, Kelsey Johnson. She has an MPH and is a research coordinator at the Beth Israel Deaconess Medical Center Psychosis Research Program. She has her MPH degree from BU, School of Public Health, and works in research regarding the early detection and treatment of psychosis spectrum disorders. She had a leadership role in the design and development of the resources we're going to be talking about today. So before we get into this, just to remind you, please remember to use the question function to ask questions, or you can also raise your hand virtually with that function on the Zoom interface, and we'll be glad to unmute your line. And without any further ado, I'll hand it over to our distinguished speakers.
Thank you very much, Barry. And thank you everybody for joining today and really partnering with us in this important effort. You can see our disclosures here, and I really want to highlight that the resources that we're discussing today have been, their development has been the result of a very generous grant from the Sidney R. Bear Jr. Foundation. And also tremendous support from MCPAP in getting these materials out to all the practices in Massachusetts, and more are available if any practices need to request additional hard copies. Please feel free to reach out and ask for those. So go ahead, Beth, and go on to the next slide. So I also want to really give a shout out to the Prevention Collaborative and key contributors to this work. This is really the product of a wonderful collaboration between pediatricians, psychiatry, specialty care, behavioral mental health specialists, researchers, people with lived experience, and their critical feedback really made this what it is. So thank you. Go ahead, Beth. So today we're going to, Emily's going to really talk about the experience in the clinic prior to these resources, but really the core concept of what we're talking about. I'll speak a little bit to the big picture that informs this work, and Kelsey's going to walk you through the actual components of the booklet and card, and also help you just be familiar with what's available on the website. And feel free to click on that and get that open as we're talking. So I'm going to pass it off to Emily.
Okay, thank you. So I'm here to present an example of a young, at that point, young teen, or who I was a patient in my practice. And just to give you a little bit of a background about me, as Barry mentioned, I am a nurse practitioner at Dot House Health and have been there a long time. And I became interested in this topic more through my academic position, where I was teaching a course on prevention of mental health conditions and learned about psychosis prevention. I think I was quite surprised that you could prevent psychosis, or that one should be screening in primary care. So I thought that I would share my experience with this patient and my experience screening. So this was a 16-year-old Vietnamese youth, we'll call him Billy. He lived with his mother and his sister. He was a really bright, high-achieving kid. His mom was a primarily Vietnamese speaker, although she could communicate adequately in English. She was very committed to her kids and very focused on their achievement. And I'd taken care of both Billy and his sister since they were young children. Next slide. So he was always a little bit of a quirky kid, not particularly outgoing. I always thought he was kind of more academic than his peers, but around age 16, he presented at a routine exam, and he just seemed different. He had very little eye contact, quite flat affect. It was just hard to get him to talk about anything. I'd come into the room and he was laying there with his earphones on, his eyes closed, and kind of didn't acknowledge me when I walked in the room. As part of our routine care, I administered the PHQ-9, and he scored really high, but it just didn't seem like depression as I'd seen in many other children. Next slide. So, well, could you back up a minute? So we did not have the tools that, that you have now that have been recently developed. And I just wanted to kind of link what I saw to the FACS algorithm on the new materials. So I think the first, in terms of thinking about Billy, was looking at his functioning and wondering if there was something different going on there. Could you, and then the second was speech. So his, the affect and just the way he was conversing with me, again, seemed somewhat unusual. Okay, we can, next slide. So I ended up treating him with an SSRI, and there was some improvement in his depressive symptoms, but his affect was still really quite unusual. And as we talked more, he acknowledged like some strange visual experiences, and he was sort of intrigued by them. He knew they weren't real, but he describes kind of seeing some shadows and then wondering if they were, like, why was he having these? And he just seemed like there was something more going on, more than depression. So I had learned of using the prodromal questionnaire, so the early screening for psychosis, and thought that it would be really helpful to use that to get a better understanding of what was going on with Billy. Next slide. So could you go back to the atypical? Sorry. Okay, so again, the going back to the FACS algorithm and thinking about what might be signs of psychosis. Again, the strange visual experiences would be something that one could think of as sort of being atypical, and again, alert one of potential psychosis. Next slide, please. So I was aware of the CEDAR program and I called them. I really wasn't exactly sure what was going on, but thought that this was something unusual for me and not something that I felt our health center really had the resources to deal with. And what actually worked out terrific was that the CEDAR clinic staff met with Billy and his mother in our office. She was not comfortable with the idea of mental health treatment. She was concerned it would kind of influence or jeopardize Billy's sort of academic career if someone found out that he needed mental health services. But she did recognize that there was a concern and was willing to meet with staff in a safe place. So what actually happened was he was enrolled in a research study that provided ongoing monitoring and support, and that worked out incredibly well. It also was, staff had the ability to collaborate with Billy's school, where the school nurse was absolutely amazing in checking in with him and really helping kind of get a better sense of how he was doing at school. So I think that I'm going to turn it, well, actually, I'll just, one more slide for me. What I learned was when he went to the CEDAR clinic and was able to have a full assessment, that actually the sort of strangeness or atypicalness of his thinking was much more apparent than, I think I had appreciated. He did have thoughts that people could read his mind, that he was being watched. He had some examples of some sort of unusual speech pattern. But I think the part that was most, at least concerning to me, that I wasn't aware of was some of the atypical features about sort of hearing this fuzzy music, seeing these brief figures or people or shadows near him, and then beginning to hear voices. Next slide. So I'm going to turn it over now to Kristen. And I guess just in reflecting on this, it's not something that I think I've had that much experience with, but I think knowing to think beyond just what I usually see, which would be depression, and realizing that some things that don't match up warrant extra work and that there are resources to help us has been really helpful. So thank you.
Thank you so much, Emily. Your example really highlights, in my opinion, the real role that primary care can play in recognizing early warning signs that, you know, without your intervention, we have no idea how long it would take for this young man to have gotten more specific care. But as this slide illustrates, and we all know, kids don't hold up a sign to let you know what's happening inside their minds. And this is particularly true for the most, you know, severe indicators of emerging mental illness, which are psychotic-like experiences. So they need us to provide safe opportunities for them to share these experiences with us. And up to 75% of those who develop most severe, you know, psychotic disorders will not have sought help before a crisis that places them in the emergency room or the hospital. So just think about that volume, 75%. Those are the kids we're trying to seek, we're trying to reach and identify, and many of those who do seek help will seek it from primary care rather than mental health because of fear of stigma. So we're just asking you to have psychosis on your radar and helping. We want these resources to help you know how to have a conversation and to you know, be able to triage. Next slide. So it's wonderful again that you're all on the webinar and looking at these resources, because we need help challenging the myth that major mental illnesses begin in adulthood. 50% of major mental illnesses begin by age 14. Next. And 75% by the age of 24. So adolescence into early adulthood is a real key period for the emergence of these symptoms and the opportunity for detection. Next. We have some of the best data on psychosis in studies of schizophrenia, but this disorder, although most associated with psychosis, is only one of the major disorders involving psychotic symptoms. So I can't emphasize that enough. We're not just really looking for schizophrenia, but this is the source of a lot of what we understand about psychosis. So this is a graph of incidence or new onset by age. And the top line are males and the lower line are females. And as you can see, can you click, Beth? The incidence really increases during adolescence. And next click. So rapidly between ages 10 and 14, and doubles again between 14 to 18. So you see this really sharp rise during a period where there's a lot of change. Next. So it's probably this phenomenon that makes it hardest to spot, the idea that these symptoms are emerging during a period of a lot of change and a lot of new kind of behaviors and presentations that you may see. So even though adolescents have more eyes on them at school, et cetera, the first signs of psychotic disorders typically fly under the radar, and delays to treatment are longest actually for kids. I tend to think of this as our interest in seeing resilience and assuming the best. And what we want to challenge you to do is to have the courage to respond. You don't need to pretend that your understanding of that kid's future is fully formed, but don't use that to delay. That if we take a wait and see approach, the critical period, you can click, yep, the critical period for the brain and for important health outcomes may actually close. Next. So if we go back to this graph of incidence and we think of this delay of 1.5 years, click. this is really what we're looking at. We're looking at the onset beginning, before age 14, and many of the kids that we see come in and talk about symptoms starting at age 9, 10, 11, 12. And that this really sharp increase is by age 18, so really in our adolescent population. Next. This graph is on the website, and it's in your booklet. Just to orient you to this, the y-axis is the overall health and functioning, with higher being better, and the x-axis is age. And if you look at the blue-green segment, this is the period of peak onset of major mental health disorders marked by psychosis. The red line is somewhat typical course for a major psychotic disorder, with the first intervention specific to this acute onset often being in emergency rooms. And our goal, the one we need your help with, is the blue-green line. So we do have evidence to suggest that with intervention earlier, when the symptoms are just emerging or are milder, and we hope including in primary care, that we can avert the crisis and some of the chronic morbidity that can come if left untreated. So responding quickly is critical, and it's critical for a range of patient health and well-being outcomes. And we may not need to respond within 15 minutes, like with stroke, but if we know the warning signs, timing does matter. And importantly, next click, recovery can be a realistic goal with timely help, which I think is something that people don't realize about these illnesses. Next slide. So there are major health implications for early detection and management of psychosis and psychosis risk. The most obvious one is at the level of the brain, as we know that normal synaptic pruning and brain development are disrupted, and we have reason to believe that we may be able to interrupt this process. There's a lot of research that is emerging with promise for having interventions that can protect young people at the level of brain development. The other area of particular concern in this age group is the risk for suicide, which is highest in the first year. So intervening responsibly and early can literally save someone's life. And then, as is on this slide, economic outcomes. So for, particularly relevant when we're thinking about accountable care, that early intervention and investment in resources early on can reduce costs largely by reducing hospitalizations and emergency room visits. And this is a graph from a study of a catchment area before and after the implementation of an early intervention program. Next. So I want to just acknowledge the tension of what we're trying to do, is that we're talking about the challenge of recognizing in an adolescent population when something very serious may be emerging. And as you can see from this graph, about 17% of adolescents will have psychotic-like experiences. So only 3% will develop a psychotic disorder. But we're really looking at a population in that 17% that is at much higher risk for a number of poor outcomes, including higher rates of suicide and higher rates of persistent mental health problems. We're, in our booklet and resources, going to try to help kind of where someone may fall in a stratified risk profile and what to do according to the level of risk that we can understand with the current tools. Next slide. And this is another picture just to illustrate again, kind of, you can see our titles on the right side of recognizing the signs of who and when to screen, finding the words to then, with this group of people, be able to sort through what level of risk we think they have and what level of, or what type of intervention might make sense, so to make the connection. And the bottom groupings in these colored, the color categories for the people represented here, this is a 3-year follow-up diagram for young people who were referred for specialized care. And the largest group is the light green group, which is people who do not develop psychotic disorders, but will have persistent mental health disorders. So even if we're picking up people who are not headed for bipolar disorder or schizophrenia, we're picking up young people who really need significant mental health attention. The darker blue-green group is the group headed for major psychotic disorder, and the orange group, those who will have persistent psychotic-like symptoms. Both of those two subgroups may be most appropriate for specialized services. Next slide. So I just want to emphasize that our specialized services, the structured interviews that we use now, and there's increasing availability of risk calculators that pull in other risk factors other than what young people can report to us. That we currently can predict those who will transition to a psychotic disorder in 6 months, 1 year, up to 3 years, with a very high predictive accuracy. And then just remember that those who do not transition still have substantial risk of significant mental health problems. So it's not like the majority of those are not without mental health concerns that need attention. Next slide. And then finally, I just want to emphasize the role that we think primary care can play in joining with this goal of reducing the period that psychosis is untreated, recognizing young people who may not seek mental health care, but may come to you with concerns, and also recognizing that primary care practices are in such a good position for what we call non-specific early signs like insomnia or new problems with attention and focus. And in the FACS acronym would be functioning and cognition. So we really believe primary care practices and pediatric primary care practices specifically are uniquely suited to catch early signs because of seeing youth on a regular basis or having long-standing relationships. Hopefully knowing some of the family history of mental illness and asking about that. And the setting really is associated with lower stigma, so has an opportunity to provide some of the initial education. Next. And just want to acknowledge that we're talking about balancing potential benefits and risks of early intervention. So this really, we want to advocate for an active and thoughtful response to signs and disclosure of symptoms, not a knee-jerk reaction. Curiosity and hope that are key to really helping young people disclose what's going on inside. And a collaborative and practical problem-solving approach that really utilizes MCPAP and CEDAR and some of the other resources that are available in Massachusetts to make the connection. Now I'm going to pass it off to Kelsey, who I just want to highlight is really responsible for a lot of the beauty and the organization of this booklet. So go ahead, Kelsey.
Thanks, Kristen. Thank you for that introduction and all of this that's been talked about too. I just do want to bring back is anything that we came from the booklet is rooted in the experience of Kristen and Emily and other clinicians who have done this work. So thank you guys for that. So overall, before I start, I know some people have gotten the paper versions of these booklets. If you have that in your hand, that would be great. If you don't, you can also go to psychosisscreening.org. And there is a button on the front page of that to open a digital copy of this booklet as well. I'm going to be talking through it, and there will be pictures of it on the slide, but it might be helpful for some people to be able to flip through it themselves. So again, psychosisscreening.org if you want to be going through this alongside me. But so overall, what we have in here, as has been said already in this talk, is these 3 sections. So the first, know the signs, is just warning signs to be aware of things that might pique your interest and thinking about potential psychosis spectrum disorder. The second section is once you have an idea of an experience, how do you ask more about that? How do you get more details that are helpful to you? And then the third section is really make the connection, this action-based approach of what do you do to help these people? So we have 4 paths that we've identified for potential next steps, depending on a person's risk profile. So at the beginning of the booklet, we just have these summary pages. So this is everything at a glance, and all of this is I'll describe in more detail. But yeah, so know the signs is who to screen. The next one is how to screen. So at the next slide, that's the find the word section. And then the next slide is what to do after you've identified somebody. And I do want to highlight, I'll go into this in more detail later, but if you go to the next slide, in this section, we also have a flow chart that kind of integrates that information from that you might get from somebody in that know the signs, find the words, getting more information from that person. This will help you to decide where they fall and is the sort of decision-making process that we use when we look at cases like this. So you can go to the next one now. So in the know the signs section, this is the getting into the actual meat of the booklet now. We start off with a lot of what we've been talking about today. So general information on what psychosis looks like, what the early signs look like, and how those tend to emerge. We also have some information here about family history. So how to ask about family history, and also if you have somebody who you know maybe has a parent or a sibling with a psychotic disorder, what should you be thinking about in terms of that person's risk, and what should you be keeping an eye on for them? And then this next part here is this FACTS acronym. So we've talked about it a little bit already, but just to overview, it's functioning, atypical, cognition, thoughts, and speech. So the functioning gets to this idea of a decline in functioning. So that can be anything from school, social functioning, self-care, any pronounced difference or decline in somebody's ability to function in their daily life. That can also include behavior shifts. Atypical is these sorts of atypical perceptual experiences. So that is any of the 5 senses, typically auditory or visual. And like Emily was saying before, it doesn't have to be somebody has a full-formed hallucination. They could just be seeing shadows out of the corner of their eyes or making meaning out of sounds that maybe they wouldn't have otherwise. Then we go on to cognition. So this is basic neurocognitive disabilities in things like learning, memory, and attention. Thoughts are thought disturbance or unusual beliefs. So this is sort of delusional spectrum of thinking. So things like suspicion, having these really persistent or strongly held ideas that maybe are a little bit confusing and you're not sure where those are coming from. And then the speech is actually speech and behavior that can be disorganized for some of these kids. So difference in how they're able to put sentences together, what they're saying, saying things or making connections between ideas that are confusing, behaving in a way that you think might be inappropriate, or again, just a difference from what they would usually do in a way that feels odd to you. So that's the FACTS acronym. So if you have somebody who falls into any of those buckets, the next thing that we really suggest is to ask more about it. So that's where this find the word section comes in. So on here, just to start off, we have a few tips for talking about psychosis with patients, as well as a few established questions and some screening measures like the PQ-16 to ask about that. Then from that, there are some questions that you can ask to get more details. And these are what we determine when we get to the make the connection section, what path somebody goes down. These 3 questions are what we really look at. So firstly, what's the experience like? Is it something that you think falls on maybe potentially on the psychosis spectrum of being distinctly odd, doesn't fall in line with their social context, their medical context? And we have some ways to ask about that at the bottom here. We also have the next question that we want to know is if this is impacting them at all. And that can be a behavioral or emotional impact. So are they maybe avoiding a certain part of the hallway in school because of this? Does it bother them? Are they really upset about this? Or is it just something that maybe they are experiencing, but it's not really having an impact on their life? And then the next question is if it's recurring or progressing. So is it getting worse? Or did it happen one time 3 months ago and it really hasn't bothered them since? So that will really help you determine the level of need and the level of intervention that we want for somebody. So in the next slide, we have some case examples of what that might look like in many different cases for you to read through to get a better idea of what that actually feels like when you're talking with someone. And then next we have more information on mental health differentials as well. So a lot of people may have someone who has a mental illness. Maybe they already have a diagnosis of something else, but you're also worried about psychosis risk on top of that. So that's very common, and we have some just things to think about when you have people who maybe fit into that category, questions to ask. And then on the next slide, we have a few case examples for differentials that might be more common or more challenging. So these would be for different types of disorders. Okay, so next slide the next part of the booklet is this make the connection piece. So really, once you have started to notice something, you've asked a few questions, what steps do you actually take with them? And the first page that we have here is really what Kristen was saying before about taking a collaborative approach. So if you're worried about somebody, don't worry by yourself. So we have a few suggestions on who to contact and who to ask more questions from to really get more clarity on a case. So we also have a few guidelines on medical workup for people who are presenting with psychosis. And there's a little bit more information in the booklet about things that, like medical issues that might manifest with some psychosis spectrum symptoms. So that might be more neurological or things of that nature, maybe substance use. And then the next part, this is going into our paths now. So these 4 sections explain what you would think for a person who falls into each of these buckets. So the first bucket being somebody who this experience that they've disclosed to you or that you're worried about for them likely doesn't fall into the psychosis spectrum. They may be dealing with other things that do need attention, potentially other mental illnesses. But the idea here is to reassure them either of the normative spectrum of experience that is expected for young people and redirect them to services that they need. So maybe that is grief counseling or a neurological exam, things like that. So that's path 1. Path 2 is people who they are starting to show some vaguely psychotic-like content in their thinking or experiences, but it's not really having that impact on their life. It's not getting worse, but you do want to keep an eye on them. This is also the bucket that we would put people who have a close biological relative who has a psychotic disorder. So even if they're not showing any signs, you do still want to keep an eye on them. And so these are some guidelines for potentially screening regularly for them, or how often you should screen, and if they have any questions, how you can educate the patient and their family on potential risk. So here are a few resources for non-psychosis specific care. And as always, you can also look at MCPAP for a little bit more help with that. And then path 3 people are people who we would be thinking about as being at potential risk for psychosis spectrum disorder, or people who definitely need care for a psychotic disorder. So this is, we have a good number of examples on what path 3 people might look like, but these are people who we want them to either be getting a specialized assessment, potentially specialized treatment. And in this section, we also have some guidelines for how to manage psychosis spectrum symptoms within an integrated practice if your practice is set up in a way that that would be beneficial for you, or if you think that that would be beneficial for the patient. So there are a lot of guidelines here, and also these referral resources for these people who are at potential risk. And then, so here are our guidelines too on managing these symptoms within an integrated practice. So all of that is in under path 3. And then lastly, path 4 is people who we really need to see them that same day. They have some sort of safety risk that you don't want them to leave your office without talking to somebody. So these are people who are potentially having some suicidal or violent thoughts or impulses, command hallucinations that have this concerning nature, being very out of touch in a way that just does not feel safe to you, or being disorganized and dangerous. So we have a few resources here on how to assess safety risk and next steps to take for those people as well. And then lastly here, we have a few other resources at the end. Most importantly, the psychosis screening tools, this copy of the PQ-16, and some other additional literature that you can look at for more specific cases. I think that that's everything as far as the booklet. Is there anyone who, any questions from people as I was going through that about any of the material? And Kristen, would you like us to go through the website as well?
Yeah, I think that given that I mean, people can be writing questions while we go to that. I'm assuming that you'll want to share your screen.
I probably should, yeah.
Do that.
Okay.
And feel free to chime in with questions for people who are online, because we want to be sure that this resource is useful.
Mm-hmm. Okay, so I think that I have.
So I just wanted to jump in. It's Barry Sarvet. So we don't have any questions yet, but I was going to raise a question which I've been asked by pediatricians in the past, and it has to do with the whole issue about marijuana, usage by our teens, particularly in Massachusetts, but really all over the country, and how you kind of navigate this and sort of clinically in terms of teasing out the influence of the marijuana on many of the clinical areas that are involved in early psychosis, as well as the fact that we know that there is a relationship between excessive marijuana use, or really any marijuana use in teenagers, and increasing the risk of early psychosis, and so that's an increasingly common clinical question that pediatricians are faced with these days.
Yeah, it's a fabulous question, Mary, and it's a question we struggle with, and I think the literature is really emerging in some of the increasing access to cannabis can both exacerbate and is an opportunity for us to better understand what the link is. I think it's really important. I'm just going to kind of highlight a few features. So it's really important for everybody to know that it's not an either or. So we very often are in a situation where we know somebody is using fairly heavily and they have psychotic symptoms, and our questions to them have to do with the timing, like you would with probably any medical disorder of are the cannabis use and the psychotic symptoms linked in time? Are there periods when the person has had psychotic-like experiences and not been using cannabis, and you're looking for a substantial period so that you've got the cannabis is out of their system if they've been using very heavily? We've had kids for whom we ask them to work on reducing or eliminating their use to see how that impacts their symptoms, to try to understand better. And I've seen kids for whom their symptoms remitted, and also kids for whom the symptoms were exacerbated when they were able to reduce their use. And then we're looking at really how consistent are the psychotic-like symptoms with psychotic symptoms that are induced by cannabis use, and trying to best understand what the likelihood is that, you know, if they're not able to stop, there is a separate process. I think the other, you know, important point is to just know that the evidence suggests that if people tend to have psychotic-like symptoms when they're using cannabis, they are most likely at higher risk for a psychotic disorder. So that does not mean everybody who gets paranoid using cannabis is going to develop a psychotic disorder, but there is something at the level of the brain that seems to be more sensitive to the impact of that drug, and we need to understand that. The third piece is really understanding that there's very likely some aspects probably of CBD that are very helpful to people with psychosis. They often have trouble sleeping, and some of the young people that we see are using cannabis to self-medicate, and teasing out that risk-benefit ratio is, you know, a conversation that a physician and a young person has to have. We do not have yet randomized trials that can provide robust evidence of a causal relationship, but I think there's some pretty compelling research to suggest that cannabis elevates the risk overall and has very significant cognitive implications for cognitive functioning over time, so that conversation is important. So I don't know if that answered your question, but it highlights some of what we know at this point and what needs to be kept in mind.
And Kristen, I will add, per your last point, that something that I found interesting in a lot of these conversations about cannabis has been that harm reduction approach of, obviously, if somebody is using a lot and you're worried about them, trying to get them to reduce use, but also potentially shifting them to think of something that has a lower THC content and higher CBD content, if they're not willing to cut down completely, may be beneficial.
That was very helpful. Thanks a lot, you guys. Let's see if there's any other questions at this point. Looks like we don't yet have any questions from the audience. So I would just remind people to feel free to either raise your hand or type something in the question box if you have any questions. You guys can proceed.
Kelsey, can you shift the screen to the website, or is that not working?
Sure, I can try to share my screen. Let me pull it up here. Okay, so hopefully this will work. So pulling it up on here, is that showing up for everyone?
Yep.
Okay, so this is overall what the website looks like. It's set up in a lot of ways the same way as the booklet is, just to make that easier. So the same 3 general sections, flowchart and resources on here. One thing that we can point out here is that we do have a little bit extra room with things like videos. So that would actually be under here, what that looks like for a clinician to be asking these questions and how a person might respond to that. We have a few of these screening tools available in this section of the website as well. And then let's see if I can get...
guys have time, it would be fine if you wanted to play the video. I think it would work through the webinar. It should.
Sure. Let me see if I can...
How long it is.
It's fairly short. Yeah, so this is an example of somebody who Megan, our clinician, has given the PQ-16 to somebody. This person has expressed or checked off some things, and she's asking more about that. So I'll actually play that. That's a great suggestion.
Hey, thank you so much for coming in to see me. Before you came in the office this afternoon, your mom had mentioned that you're really disliking school lately and have been not wanting to go. I wondered if you can tell me a little bit about what's been going on there. The teachers are just like talking about me, and like I don't like it. Tell me more about that. I don't know, like they're just like always talking about me and like not other kids. Like they're always doing it all the time. Kate, how do you know that they're talking about you? I can just tell. Like last weekend, my English teacher, she followed me to the mall. She was there. Okay. What did you make of that? It's creepy. I don't know. Like we were driving here, and like I don't know, but like her car was behind us, and I don't know. Maybe they're just like always tracking where I am and like talking about me when I'm not there, and like I don't like it. Sure. When did you first start having the thought that people or the teachers were talking about you or following you? I mean, they've been like talking about me like all year, like all the time. Like anytime I'm there or not there, and then like they started following me. Like I don't know, like last week is the first time I noticed. Got it. Okay. So first they were talking about you, and then they started to follow you. Mm-hmm. You think? Okay. All right. Hey, thank you so much for answering all of these questions and sharing this with me. What I'd like to do now is talk a little bit more with you about some of these experiences, and then maybe we can pull your mom in and talk together about some next steps. Okay.
Great. So Kristen, I don't know if you can speak to, I know Megan definitely has that non-judgmental way of asking these things in a way that makes people, or opens the door for people to share things. If you have any other comments on that.
Yeah, I think she's speaking fast because we were trying to get a short video up there. So I think just really taking your time and having curiosity about what's going on and not being afraid of what people are going to tell you, and communicating that to them, that this is something that you're going to help them manage together with them, even if the answers are not clear right away.
And all of these case examples on here are the same things that you would have seen in the booklet as well. So all of this is available hard copy and digitally. And then I can go to the other resources on here as well. So this would be things for providers, some online information, and also for people and families as well. Sorry, I'm having some trouble reaching that here. Let's see. Any other comments as I'm going through this?
Yeah, I'm curious if anybody on the phone has already used these resources and wants to jump in on kind of what that's been like.
Maybe you guys could mention the card that goes along with the booklet.
Oh yeah.
Thanks, John.
I could actually pull it up on here as well. All of this from the website and the booklet is also available on a 5x7 note card. So this was just designed to be something that's a little bit more portable to have on you as a quick reference. And then knowing that a lot of these larger references are available.
So we do have a question on the question and answer section. Sonia Diaz asked, can you speak about the critical period for early intervention? Are they therapy-based, or are the interventions therapy-based or medication recommendations? That's
a great question, Sonia. So what we're understanding right now about the critical period is partly based on brain development and looking at windows in which certain brain maturational processes are occurring. So it's kind of an emerging area, what will make a difference. So the evidence base that looks at early intervention is typically based on programs that have both psychosocial and medication as part of the package. So the most robust literature we have to date is in the intervention in a first episode of psychosis. So what we've been talking about today really encompasses early signs that may not be fully psychotic or maybe psychotic-like into experiences that are very obviously psychotic. And so the most robust evidence is with people for whom their symptoms have been fully psychotic. And the evidence is very compelling that those with a very short duration of psychosis prior to their getting treatment have much better trajectories over time than those for whom that treatment comes later. And that's controlling for a number of variables that you might expect to be associated with some of those delays, but we still need to unpack some of that. There's also what we call meta-analyses, where we really look at studies that are grouped together of young people who are at risk for a psychotic disorder. And there's good evidence that we can cut the risk down by half within 1 year when we intervene with more comprehensive specialized care versus treatment as usual. So this idea that intervening prior to the full expression of psychosis can reduce the rates of transition to a psychotic period. So that's probably the best I can answer right now, but it's a very exciting field actually looking at critical periods in development and the opportunity to intervene in a way that's protective of the brain. So I see something from Eric, and not sure if you can type the question in.
Eric should be able to talk now.
Here, let me see if I can. It looks like he's muted right now.
Yeah, we can get unmuted. Otherwise, we can ask him to type and send it.
Oh, there we go.
Can you hear me now?
Yes.
Hello?
Yes.
Hi, Eric.
Yes, we can hear you.
First of all, this is a wonderful, wonderful psychosis screening and primary care manual. It took a lot of time and a lot of effort, and I appreciate it greatly. I've been in practice now for 42 years, and I go back to a case over 20 years ago when I had a tennis player who was a very good tennis player, and he kept on telling me that he was hearing voices about how to do well playing tennis. And I say, well, everybody has self-talk. And he went on to becoming schizophrenic. And it's a case that I will never forget because I felt very remorseful that I missed it on that first interview. So self-talk was a little bit more than self-talk. Now I want to go to another issue, and this is where, when you're talking about cannabis, I am the only certifying pediatrician in Massachusetts for patients under the age of 18 in the Cannabis Control Commission. And I've been doing it now for 4 years. So I do take a little bit of exception by some of the blanket statements that were made. I want you to look at Prozac and the black box warning for all the anti-anxiety medications that say if you use it, your patient may end up committing suicide. But doctors, pediatricians are particularly still using Prozac. Yes, they caution their patients. So I have a number of extremely anxious teenagers who do medicate themselves for their anxiety. And they tell me over and over that cannabis is helping them much better than Prozac, much better than Zoloft, much better than the Ativan or the Xanax that they use for panic attacks. I think it's very important to ask the question, are there people in your family who have mental health problems that have necessitated either hospitalization or significant treatment over time, including electroshock therapy? If you get that answer, then those are the ones that I talk to about, you know, your use of cannabis may potentiate and exacerbate a psychotic issue as your relative. But I want to go back to the Prozac because not all of these medications work for their patients, and I tell them in the cannabis, not every cannabis user it's going to work for them. So, but I particularly, and this is where other physicians don't understand, there is CBD and there is THC, and there are milligrams that you talk about. CBD up to 25 milligrams, CBD up to 50 milligrams, CBD up to 100 milligrams. And there's THC that you talk. I'm going to be finished in a second. I'm sorry. But,
okay.
So it is extremely important to know what their ratios are of CBD to THC or THC to CBD or CBD equal to THC. And it's extremely important to know what the milligrams are. And it's also important to know, are they doing it once a day, twice a day, 3 times a day? Are they stoners or are they using it for medication? So I say whether you are for it or against it, we need more research. And more research is going to open up this field, because I can't say that it always causes psychosis or that it never causes psychosis, but you can't tell me about Prozac being that much better. So I'm going to stop now, and I just wanted to give the other side because nobody is giving the other side. 4 years of doing this, I haven't had anybody kill themselves, and I haven't had anybody hospitalized. But
okay, so I'm going
to opportunity.
Thank you, Dr. Ruby, and this is not, I'm not cutting you off for editorial reasons by any means, and I think we can all agree on the need for more research, but we have actually gone past the end of our time, and we've pretty much lost our audience. I think we just have a couple more people on the line. So you guys could answer that really, really briefly, and otherwise we can take that as a comment, you know, really. But do you have any responses to that really quickly from our panelists?
Yeah, I think thank you very much for your, sharing of your case and recognition of the value of this work. And I just apologize if I made statements that sounded like they were black and white. I do not see it as a black and white issue. I just think that this is a population that is particularly at risk and vulnerable. So the conversations need to happen in a very thoughtful way.
Thank you. I agree.
Okay, so I do want to thank, first and foremost, our panelists who have done a wonderful job with the presentation, and we're so impressed. You know, I want to join with Dr. Ruby in terms of the admiration for the the publication in terms of the toolkit and the work that they've been doing. So thanks to all of our participants as well, for those who are still on the line. And please feel free to send any further questions to mcpap@beaconhealthoptions.com. I do want to remind people about the survey and also about the fact that the recording of this webinar is going to be available on the website very soon. So thanks, everybody.
And we're happy to send out additional copies of the booklet if people are interested.
Great.
Thank you all. Thanks for people tuning in today.
Thanks.
Thank you.